Our next speaker is Caroline Canton. Caroline is a social worker by profession. She's worked in Naval Ireland and Tallaght for over 20 years and is the National Programme Coordinator for the Progressive Disability Service for Children and Young People. Her talk today will focus on three relevant joint working protocols that the HSE and Tusla, the internal HSE protocol capturing primary care disability and CAMHS, and also the protocol with AIM. So I'll pass it on to her now, please.
Thanks very much, Sarah, and hello everyone. Delighted to join you, and it's been really interesting the day so far. All right, so as Sarah said, I'm going to be talking about the joint working protocols. My first slide there about collaboration, integration, etc. I don't think I need to go over that again. I think it's been really well covered by Bernard just now and by others earlier today. So I think we're all on the same page there. So the three joint working protocols that I'm going to talk about are putting on the structure, getting the right skeleton, if you like, there for us to work far more closely together. So those three protocols are what I'll be going through. Just to note that wherever health services are mentioned, or even the HSE is mentioned, they all refer to and completely include all funded agencies, both in the HSE, the Section 38s and Section 39s, and the funded agency that Tusla has. So don't be thinking that they've been ignored. Okay, so I completely sympathise with this view. These protocols don't really make for light reading, not the sort of thing you'd be picking up very readily. However, what I want to do today is really emphasize how useful they can be to sort of promote those structures, especially between divisions that Bern has just talked about and between agencies. I'm hoping to give you some key points in those very quickly in this short presentation, just to sort of give you, sort of highlight things for you in the three protocols. Also to say that each of them has flowcharts, which can be very helpful to sort of give you a summary and give you an idea of what you're supposed to do and how you're to proceed. So firstly, this joint working protocol between primary care, disability and CAMHS. And again, we've heard about the needs. I don't need to go on too much about the children's needs crossing services, children with disability, children with intellectual disabilities, we've just heard, who have a fairly high risk of mental health issues as well, and how we need to work together on those. I was on the working group for this particular protocol, and we heard really distressing stories about referrals going back from one service to another. And a lot of the time you feel that criteria for access to services is more about excluding than including. And I can completely understand. I was there putting up fences to protect your service. We've all got finite resources, and we're trying to provide the very best service we can for the children receiving those services. And we tend to put up those barriers to control the huge demand on our services. But so we put up the fences, and if I don't get too carried away with the metaphor, I think we need to make sure we've got gates in those fences that we can talk across, or maybe even lower the fences so that we can communicate across the different services and not just build up these silos. And as Niall said much earlier, we need that flexibility to look at children's individual needs. So the recommendations from this protocol are, not surprisingly, much higher degree of collaboration. We need seamless access to services so that children can access, again, back to Sláinte Care's slogan, right care, right time, right place. We need information available for referrers and for parents and families on where to access services and how to do that. We need a much greater, much more fluid consultation between services, that people can lift the phone and get a consult. For instance, again, a child attending a Children's Disability Network team, if there's a mental health issue, to be able to lift the phone and talk to a counterpart or somebody in CAMHS or CAMHS ID on an informal basis, as well as proceeding to maybe a more formal consultation. So we need that joint working, which includes joint assessment where it's needed, joint intervention. I was also on a group that was looking at services for children who are deaf and hard of hearing. And again, we had lots of distressing examples of children for years not getting the right assessment. Children who maybe had, who were deaf, but also had behavioural difficulties as an example, and no one service being able to provide the right assessment for that child. They need to work together. You may need psychiatry working with the disability staff to do that joint assessment. And a very key recommendation from this protocol, very dear to my heart, is setting up the Integrated Children's Services Forum, which I'll be talking about in a second. Firstly, just to look at this, here's one of the flowcharts, or I've rather simplified it on this slide, but there are full flowcharts in this protocol. So if you look there, a child has different kinds of difficulties. So the referral goes in those blue boxes, either to primary care or to the Children's Disability Network team if that child has a disability and complex needs, or if they have a moderate severe mental health disorder, to CAMHS. And obviously the people in those services look at that referral, study all the information they're given, and make a decision one of three ways. So in the pink boxes, if this is the appropriate service, great, away we go. Child moves onwards to get their assessment and any interventions they require. If a service is clearly, it's another service that would be more appropriate, this has come to the wrong place. So therefore, the receiver of the referral, that receiving service, redirects that referral. It may be that it has to go back to the referrer, but they inform the family, or they get permission to actually directly send it on to the other service. If there's difficulties arising out of that, they can refer that referral on to be discussed at the Integrated Children's Services Forum. The third alternative is, from this referral information, you can see there's more than one service is required for this child. So again, discuss with that service how you can do joint working, but if necessary, again, refer it on to the Integrated Children's Services Forum for decision and discussion and decision. And that's where we are now. Here's the forum. So this is the forum which now makes final decisions, which means there's an end to the to and fro of referrals going from one service to another and never managing to land. This is a forum with senior managers advised and bringing in frontline clinicians as they require. And it is led by primary care, disability services, the Children's Disability Network team, and by CAMHS. So they lead this forum. They will be always at this table, and then they will bring in others as are needed according to the child that's actually going to be discussed that day. So it may be education, maybe the school needs to be involved, or it may be Tusla, or it could be the acute hospital, whoever is needed to be in there. And really the whole point of this is to get people around a table. And as you will all know, if you get people usually around a table discussing it, everybody has the child's interests at the center. And that's why you can form those decisions with the child's best interests. And we do have, it's taking a little time, but we do have some integrated children's services committees around the country in the HSE, and they're looking at actually setting up these ICSFs, and they should be in every local area in the future. Okay, moving on now. So this is the joint protocol that has been referred to a couple of times today between Tusla and the health services. And Bernard's obviously talked quite a bit about this. And it did arise, well, I think it actually was 2017, so it was around the same time as the Molly report. So already recognised we've got issues here, but the Molly report obviously focused minds even more on what we need to do. So obviously the focus here is children and young people whose needs cross health services and Tusla, and there's the various issues we've already heard about. Now, I was glad to hear from Bernard that the issue around funding is getting sorted, that, you know, professionals on the front line, as it were, don't have to have that concern about who's going to foot the bill for whatever is required. We need that sorted. One of the key recommendations out of this protocol is the need for really good transition planning for young people who are maybe in care now and have disability or mental health needs. And that needs to start really early. In the report, it says from their 16th birthday. We need to involve that young person very much, as Catherine was saying earlier, hear their voice, hear their views. It's their lives. They have a right to decide on how they want to live their life. And we need to support them to do that. But we should be all getting around the table again at an early stage, not, you know, shortly before they're going to leave care at the age of 18. So that's another very important part in this protocol. These are the flow chart, the pathways. So if there's a concern raised by health services or Tusla, obviously we have the recognised pathways to a MEHL or interagencies approach to notifying Tusla under Children First, and then to the local aftercare steering committees. Again, as I said, on their 16th birthday, they should start looking at what children's needs are and should be involving health professionals in those discussions and those decisions. So the protocol is advocating for joint working at local level. I'll talk a bit more about that in a second. Any unresolved issues, hopefully not too many, can be escalated to an area joint working group. And again, they're joint, but as between the health services and Tusla. And those are now set up in all parts of the country. Then again, hopefully not too many issues will not be resolved there, but there is a path for escalation. In other words, it doesn't have to get stuck at a certain point without being resolved. It goes upwards. So just that joint working at local level, what's recommended in the protocol is very early engagement. Early warning signs, early warning systems, I think are mentioned. Get talking early, have informal consultation between services, flag issues that you can see are going to come up. Maybe, for instance, when a young person's going to be leaving care and they'll have ongoing needs. But younger children as well, as Niall said earlier, you're probably going to have a fair idea on some of the needs the child has from very early on in their life. You don't have to wait until they start to really become clear. Any professional could then, if they still need more work to support a child or young person, they can call an interagency meeting. And at that meeting, they can develop a joint care plan. And those are that's the kind of outline of what you should be doing, agreeing who's the lead agency for this child and this family, and which professional is going to be the key coordinator for that. Identify the interventions wherever those need to come from, across the health services, Tusla, etc., whoever you need to involve. And again, if you can see that a need cannot be met, and we all know that there are those, and again, finite resources, advise line management. This is going to be an issue. We need to have this resolved. And the area joint working group can step in there as well. So that's a very quick flyby of the Tusla HSE joint working protocol. So the last one I'm going to talk about briefly is the AIM joint working protocol, which actually I think, I don't have the full title there, but I can tell you it probably has the record for the longest title of any document. However, we will call it the AIM joint working protocol. So I'm sure, well, those of you certainly who work with children will be very familiar with the access and inclusion model of supports for children with disability in preschool. And the whole focus of AIM is to maximise the child's participation in preschool. And it has the 7 levels. The first 3 of those are universal for all children in preschool, for all information for parents and for preschool providers, and then supports in terms of training for the workforce, for preschool staff. So this protocol is about the next 4 levels, 4 to 7, which are the targeted supports. Right, so level 4 is expert educational advice. And this is the role of the early years specialists who will be providing that direct support to preschools. They need to build up a strong relationship between with the health services, particularly the Children's Disability Network teams, but also primary care. And if the child is known to a health service, if the EYS feels they need a bit of support, maybe they're not feeling the child is still, despite all their help, is not participating as well as they could, they should contact that health professional to review what strategies are being used and to get suggestions of what else could be done. If the child is not known to a health service, they can contact them again to seek, without knowing obviously the details of the child, the health service won't know those, can seek appropriate universal strategies to use. They can also refer, obviously all of this with parental consent, can refer to a team, a children's disability team or a primary care service if they feel that's needed to support that child. So the next level is level 5, which is about equipment and minor capital alterations to preschools. So again, a lot of this is that the preschool and the parents will make an application for funding for these. The health professional's role then is to confirm with the EYS that it is this equipment or this particular adaptation is critical to this child's participation in preschool. They may feel that they need to be present for the setup of, if there's a particular piece of equipment and a physio or the OT is needed, for instance, they may advise that they should be there to actually set up that piece of equipment and to provide the preschool staff with any training that's necessary. They can also provide advice on equipment which may be transferred with the child from preschool to school, which obviously makes a lot of sense. Level 6 is health service support. So this is where the health service really comes in to support the EYS and the preschool. There are 2 levels here. Again, universal, giving information, more information and advice to the EYS on the children's particular needs. But then there's the level of targeted support where an individual child requires intervention and support plans, and the health professionals can work closely again with the preschool staff and with the EYS to provide that support. Finally, the level 7 is additional capitation, and this is usually where the preschool feels that they need the monies to be able to employ an additional adult in the preschool, which would lower the child to staff ratio and therefore help them support the child with the disability. This is the role of the EYS to recommend whether this is required. And it is not actually the role of the health services to get involved in that application, except to provide copies where they have pre-existing reports. So they shouldn't be asked to provide more reports. They shouldn't be asked to provide letters. But they can, obviously, if it would be helpful, provide any information they already have. Okay, so finally, where can you find these protocols? You can find them under key national documents in the PDS pages, the Progressing Disability Services for Children and Young People pages, which is obviously my main job here, but I haven't talked about PDS today. But you will find a lot of information on that website, so do visit it anyway. And then there's the direct link there. And as I understand from Claire and Sarah, you will get access to these presentations, so you don't have to hastily try and copy that down now. You'll be able to use that link. So just to say, to finish up, we need to realize these protocols. We need to set up our integrated children's services forums, etc., and really use them to help us to bring about greater integration. Okay. Oh, goodness. The first question here, would Caroline please comment on the fact that there are no social workers on many primary care teams? Very interesting. I do know of some colleagues in primary care, but I know it's relatively new, and I suppose I wouldn't want to comment too much because I wouldn't be that familiar with primary care. My history has all been in disability services. I would agree, why would I not, that there should be social workers on primary care teams, and they have a huge role. One particular one I knew when I was working in the Dublin Southwest area was excellent, all the work she was doing, which was brilliant. Transition is so important, yet HSE funding allocation is so late each year. Please note, no transport for school leavers, where some young people have been availing of transport for, in some cases, over 14 years. Absolutely, I'd agree. And every year, there's colleagues of mine in the National Disability Offices working on school leavers and getting that funding. And I couldn't agree more. We need to get that. Just as we're saying, transition should be planned a couple of years in advance. We need that funding to come much earlier, and for people to feel secure in that. Can you comment on the key role social work plays in the process of integration of systems and the growing reliance on assessment and clinical treatments that are more focused on treating the specific problem at hand? Well, you come to the right person with that. I would absolutely agree. I have heard people call social workers on the Children's Disability Network team as the oil to grease the wheels. I know we've already heard oils, communication is the oil of collaboration, but it's also oil within a team to make it go. I've also heard it described as social workers the jam in the sandwich, so maybe that's even more fundamental. Absolutely, I think social workers are so well placed to really see outside, to see the full picture, to really look at all the needs of the family and the child and see all those other factors. Why something, I think Catherine was it, talking about, if things aren't going well, there could be lots of other things going on for that family, and social workers are an absolute key point of observing that. We will hope, just to verge a bit into my PDS role, the ambition would be certainly to have social workers on every team, along with all the other professionals we need. And we are at the model, the PDS model is interdisciplinary teams, and therefore everybody working really closely together as a team. Is that the last question? Okay, thank you very much. Righto.